Hi, everyone. I think we'll go ahead and get started. I'm Elizabeth Cruse. I'm one of the internal medicine physicians here at Valley View, and I just have a few housekeeping issues they want me to go through before we get started. Just want to say again, welcome to Valley View University. This is the Women's Health Series, and I'd like to thank you all for joining today. So you can submit questions through the Q&A chat on the bottom of your screen. Your question could be answered during the presentation in the Q&A chat or live at the end of the presentation. We will try our best to answer your questions. We are unable to answer questions regarding personal health information, however. So just not asking any questions about your own health issues. That would be great. All right. So I'm just going to share my screen here and we'll get started. All right. So this is a really big topic. It's much too much to cover in 30 minutes, but we're going to try to cover things. Really, what I tried to do is focus on the most common questions I get from my patients and areas of confusion I hear about often. We're also really going to focus on really natural menopause and not some of the other issues that can happen around this time. And also going to focus really on evidence-based treatments and so because there's a little bit of controversy in some areas. So just a disclaimer, none of this should substitute for your own visit with your own physician. And so I just really wanted to start with this quote. Connie Huck is a screenwriter and a television personality, I think, from Britain. And I really liked this quote because I think until fairly recently, menopause really wasn't talked about unless it was really part of a joke. And I think that's really changing. I think it's also because culturally, women aging isn't something that it's been allowable. And hopefully that's changing as well. So in the United States, the average age of menopause is around 52, and our life expectancy is around 79. So we're going to spend a third of our lives in menopause. So it is really something important to talk about, especially if you're having symptoms that are making your day-to-day life difficult. And really at age in perimenopause, which is the time anytime like 10 years or more before you actually enter menopause, we're in the prime of our work lives and our work productivity. We're also often caring for children who are going through adolescence and going through their own hormone changes. And then sometimes we're also taking care of older parents and spouses. So there's a lot going on in our lives at this time. Some experts have estimated that there is a significant decrease in productivity that costs the US a lot of money, and they've estimated up to $1.8 billion a year could be lost because of decreased productivity in women due to menopausal symptoms. But it is a really natural process. It's something that's going to happen to all of us, and we really need to get past this cultural taboo and really start talking about it and normalizing it. I think too, hopefully one thing that's helped is having women in medicine, and because we're all going through this too. So, what is menopause? I think that's one thing that patients are confused about, because the medical term for menopause is really once you have not had a period for 12 months, you are technically in menopause. But like I said before, we can start having symptoms up to a decade before our periods actually stop. So just for further definitions, we already mentioned that the average age for women in the US is around age 52. But premature menopause, by definition, is any woman who stops having periods who's less than 40 years old. Early menopause is defined as between 40 and 45. And then late menopause is any time you don't stop having your period until after age 55. Then, of course, there's women who undergo surgical menopause, which means when you have your ovaries removed, and so you don't have a source of estrogen any longer, a natural source of estrogen. Just having your uterus removed does not necessarily throw you into menopause, although you won't have a period, obviously, anymore. And menopause really varies by genetics and race. Um, there's a lot of evidence that shows certainly that you might want to ask your mom what her experiences were if she knows or remembers, because that's likely going to reflect maybe what you experience, but not always. And then there's evidence that women of color, including Native American women and women of Middle Eastern descent, often have more significant menopausal symptoms, even once you correct for socioeconomic issues. So it can really vary depending on who you are. And you know, some women sail through menopause and have absolutely no symptoms, and that's completely normal as well. Oh, so I think I'm messing up my slides here. So I just talked about this slide, and so I'll move on. So, oh, as you probably remember from middle school biology or health class, in women, our ovaries are the source of our sex hormones, estrogen and progesterone. And these control our hormones between puberty and the menopause transition. And we are actually born with millions of eggs, but through biology, those eggs decrease until only a few hundred at the time of puberty. So we're already losing follicles and eggs way before we even hit puberty. And if you remember, the ovaries will produce estrogen. The estrogen sort of peaks mid-cycle. The estrogen levels, they will recruit what they call recruiting the follicles, which contain the eggs. There's usually one follicle that becomes dominant over the course of the cycle. An egg is released. The tissue that is left behind is called the corpus luteum, and that corpus luteum is what produces progesterone. And then that progesterone is what causes thickening of the lining of the uterus in preparation for potential pregnancy. If the egg is not fertilized, of course, then all of that lining sloughs, which is what we experience as a period or vaginal bleeding, and then that whole cycle starts over again. So eventually, though, what happens, as I mentioned, is all the follicles or eggs are depleted as we go through life. And once this happens, we begin to have symptoms that are related to perimenopause. So in perimenopause, the cycle of follicular or egg maturation becomes much more irregular. There can be a shorter maturation time. More follicles can be recruited per month. So that's why twin pregnancies are sometimes more common as we get older. Estrogen levels can decrease and become irregular. Ovulation becomes irregular. So, of course, many women notice that either the period becomes shorter or it becomes longer. All of that is normal. But they can also start to experience even some of the symptoms that are associated with stopping your periods, even though they're still having periods. They can have hot flashes, mood changes. They'll notice changes in their sleep pattern, among many other symptoms. And eventually what happens is that the production of estradiol and progesterone completely stops. There's no more egg production, and that's what leads to the complete stop of periods, and thus the definition of menopause if you've had no periods for 12 months. So as we've kind of already mentioned, the symptoms can really vary from woman to woman. Like I said, some women have absolutely no symptoms. But the most common are, of course, those vasomotor symptoms, which are commonly called hot flashes. About 80% of us going through menopause will experience some of these. For many of us, or they say the average length of time that these symptoms will last after menopause is about 4 to 7 years. But many women will have hot flashes for the rest of their lives. Mood changes are extremely common. About 40% of women experience depression during menopause. And then other common symptoms include genitourinary changes like vaginal dryness, which occurs in about 50% of women, urinary incontinence because of the loss of estrogen, which leads to thinning of the tissues and decreased elasticity of the tissues in the vaginal area. You can have more risk for urinary tract infections, weakness of the pelvic floor. Another very common thing that I hear from my patients are about weight changes. What women often notice is they start to gain weight more in their abdomen rather than in their thighs and their breasts when they were younger. It's really not clear, however, why these weight changes occur. Much of the evidence we have so far indicates that these weight changes might be more related to aging and lifestyle changes rather than actually the changes in our hormone levels. There is a decrease in lean body mass, meaning a decrease in muscle mass and having more fat, that occurs in everyone, male or female, as we get older. And as you can probably imagine, we're not as active maybe as we were when we were younger, and that really doesn't help with the weight gain issue. And then, like we mentioned before, sleep disruptions. Really, if you're not sleeping well and you're fatigued and tired or stressed, that really can lead to poor diet choices. And many of us are not motivated to exercise when we're tired and not sleeping well. And then this weight gain, which tends to be more abdominal, can lead to an increased risk of some of the metabolic syndromes that we see as people age, like high blood pressure and risk of diabetes. And plus, apparently, this abdominal fat is harder to lose. And really, studies haven't really shown if hormone therapy helps. And we're going to talk a little bit more about that in a bit. And then again, like I've mentioned before, I think that to the weight gain issue, the increased stress that's happening at this time of our lives, just with everything we've got going on, certainly doesn't help either. So another question I hear quite a bit from my patients is, do I need lab testing to see if I'm in menopause? And the answer is really no, as you can see from the slide. Really in the right context, in the right person with a appropriate menstrual history and age, that's all you need to know. Really, as always, the other reason is because, especially in perimenopause, from day to day, your hormones fluctuate. So one day they could be normal and the next day not normal. So getting a blood test is really not very helpful. Now, there are some patients or some people for whom they may consider testing, someone who's been on oral contraceptives throughout her 40s and into her early 50s and wonders if they have hit menopause. That might be appropriate. And some other clinical situations, testing may be appropriate. So it's a good thing to talk to your doctor about. But for the majority of us, there's not a lab test that tells you you're in menopause. So the next question I hear most often is, do I need treatment? And really, this is an individualized decision. Again, like we talked about, menopause is normal. There's no need to treat it. But if you are having symptoms that are disrupting your life, it is certainly worth considering. Treatments certainly are not going to halt the normal aging process. They're not going to prolong your life. But there are some measurable benefits for sure, especially, like I said, if you're having symptoms that are interfering with your life. And as an individual, you really have to consider the benefits in context of your risks and your own personal medical history. So that it's definitely worth talking to your doctor about. So what are your options? You have a lot, actually. So first, we all like to talk about or start with lifestyle management. Of course, you all know about hormone replacement. I'm sure you've heard about that, but there's also a lot of non-hormonal therapies for these symptoms. And then, of course, the literature or lay literature is full of complementary and alternative medications, which we'll touch on a little bit. So let's just start with lifestyle, because this is the thing I think most of us like to talk about first. I think there's a myth that we like to prescribe medications, but we don't really, I think. So if you're not treating yourself well, you're not going to feel well. I think what I always talk to my patients about is, you don't put bad gas in your car and expect it to run well. And there's lots of things you can do way before you hit perimenopause or menopause that can help you navigate the transition better. So, of course, eat a healthy diet. Diets rich in fruits and vegetables, beans, legumes, whole grains, low in saturated fats. Cut down on your alcohol intake because that can interfere with your sleep. Alcohol can make you feel sleepy, but it actually makes your sleep poor. Get enough calcium and vitamin D when you're young because actually our bone density peaks when we're 25. So making sure you're getting plenty of calcium and vitamin D to keep those bones strong and reduce your risk of fractures as you age is really important. I think being physically active, of course, developing an exercise routine. For some of us, that exercise is something we do because we know it makes us feel better. I always joke that every 2 weeks is falling off. I have to climb back on the wagon of exercise, but just keep at it because it will help you navigate these changes in a more healthy manner. Of course, don't smoke. Nobody should smoke. Um, and generally, also, I think we tend to put or women tend to put themselves at the bottom of the list as far as taking care of themselves. And so, really taking time for yourself and making sure you're taking good care of yourself so that you can take care of everybody else. And then the next thing I hear about, there's a lot of confusions about estrogen. So, just a little explanation about estrogen. So, there's three main kinds that we talk about. So, there's human estrogen, technically called E2 or 17 beta estradiol. We all just probably say estradiol. There's also conjugated equine estrogen, which is a type of animal estrogen that's made partially from the urine of pregnant horses. Um, and then there's a synthetic type of estrogen, ethinyl estradiol, which is the type of estrogen most commonly found in oral contraceptives. So estradiol is the prescription form of estrogen that is in all of the FDA approved medications for treatment of menopausal symptoms. The prescription formulations of micronized 17 beta estradiol are identical to the structure of the estradiol that is made in your own ovaries. Estradiol in your body is then converted to other forms of estrogen like estrone or E1. So that happens naturally when you're getting estradiol. But the estradiol is like primary estrogen that really works during our fertile years and that is produced by our ovaries. There is a term that everyone has heard called bioidentical hormones. That is a marketing term. The estradiol in all of the prescription FDA approved medications is also bioidentical, and there's no real advantage to compounded estrogen as opposed to the kind you can go to any CVS or Walgreens or other pharmacy and get. And I'd just like to say, although there are some very good compounding pharmacies for sure, there are some risks of taking compounded medication because most of those pharmacies do not have any government regulation and very little monitoring. They've done studies looking at compounded medications and they found that there's a lot of underdosing, meaning that there's not as much of the active ingredient that the doctor ordered, or there's actually a lot more than was ordered in the medication. There's questions of sterility for some of these facilities. And again, there's really a lack of scientific evidence regarding efficacy and also that it's any better. So that's just my little soapbox, and I'll get down from there and we'll move on. So if you have a uterus, the other hormone you will need to take if you decide to take hormone therapy is a progesterone. And the reason is because you need the progesterone to protect your uterus from the estrogen, because without the progesterone, and you just take estrogen, it puts you at higher risk of uterine cancer. The progesterone can be given continuously or on a cycle. And if you're on a cycle, you will have a period. Most of us are done with that, and we'd rather just take it continuously. Oral progesterone is usually preferred, but it also comes in transdermal forms. So there's two synthetic progesterones. There's medroxyprogesterone and norethindrone. But most often what we are using now for hormone therapy in postmenopausal women is the micronized progesterone, which, like the estradiol, is just like the progesterone that's produced by the corpus luteum in your ovaries when you are in your fertile years. So hormone therapies come in a variety of different forms. All of these are very effective. You can get implants, there are topical creams, gels, sprays, there's patches, and there's pills. And there's also vaginal rings that you can use. it really just depends. It really gets down to cost. And then there are some benefits to some of the transdermal as opposed to oral forms of these medications. So again, it's talking to your provider and deciding what's right for you. So what is the other thing I always hear about is, why women want to be on hormone therapy. So what is hormone therapy really approved, FDA approved to treat? It's mainly approved to treat hot flashes. That is its biggest benefit. However, it also is approved to prevent osteoporosis. So if you decide to go on hormone therapy, this is a nice benefit. It can reduce your risk of postmenopausal osteoporosis. Of course, like I said, we're not really going to touch on this very much, but women who, young women who have undergone menopause really need to be on estrogen to prevent the long-term effects of just having a longer menopausal time. And then also, hormone therapies are approved to treat the vulvovaginal symptoms we might have, the dryness, the urinary tract infections, and usually, when we're treating just those symptoms, we're just treating with local estrogen, so a cream or a ring or an ovule vaginally. The systemic or oral or other transdermal forms of estrogen don't treat those symptoms as well. You can use both together, though. So, what are the benefits? We've touched on some of these already, but main one a lot of women notice besides the improving the hot flashes is that they'll notice some improvement in their sleep. And usually this improvement in sleep is because you're reducing the hot flashes. There's really less evidence for benefit of hormone therapy when you're not having hot flashes at night. It's not really clear whether hormone therapy helps if you're not having hot flashes at night. Progesterone alone may also help with hot flashes and sleep. Progesterone makes some people sleepy and can reduce some of the hot flashes. It's an off-label use, but often we'll use the progesterone just for those reasons. And like we talked about already, is that this systemic or oral or transdermal forms of estrogen don't really help with the vaginal or urinary symptoms. And I just want to mention that if you are for breast cancer survivors, vaginal estrogen is safe. So people who have had breast cancer can use vaginal estrogen in most cases. Other benefits of hormone therapy is that it may help you retain muscle mass. It may decrease joint pain that we all experience, I think, as we get older. It definitely reduces your risk of diabetes. So those are some benefits. Where do we really have limited or no data? A really interesting one is in sexual function. Low dose, certainly if you are having vaginal pain, which is not making sex any fun, treating that with low dose estrogen to help with the vaginal resilience and improve the tissue function can really help with your sexual desire. But what we know now is that these changes that the hormones make in the local tissues is really independent of the effect on sexual function and doesn't seem to really improve it in women. We really do need a lot more data in this area, but so far what most experts say is that this is because female sexual desire is really very complicated. It's a convergence of many factors. So hormone therapy is really not indicated to treat this problem. But like I said, if desire is not the issue and painful sex is, definitely talk to your provider about using vaginal estrogen, or there's some other products, ospemifene, which is a selective estrogen receptor modulator, and the Menopause Society also says vaginal DHEA can be used off-label for the painful sex. And like we've kind of already mentioned, hormone therapy seems to be kind of weight neutral, doesn't really seem to affect weight, won't make it better, and those changes might be more related to aging in general. It might help with, there's not really great data about helping with mood and depression. We often treat those with the standard medications and therapy that we use for other people who have mood changes. There does does seem to be neutral to beneficial as far as prevention of cardiovascular disease, especially if started in women who are younger than 60, which is who it's indicated in, or women who are young within 10 years of menopause. And there's really little to no data for the remainder of these other symptoms that I think often women are looking for help with during menopause. So I just want to mention briefly a little note about testosterone in menopause. Testosterone replacement in women is really not well studied at all. It's not FDA approved. There have been some studies looking at sexual desire and testosterone level, and there really does not seem to be a consistent correlation between our testosterone levels and our levels of sexual desire. There's no FDA approved delivery method or dose for women. However, certainly people or providers do prescribe testosterone for women who are suffering from decreased sexual desire. And the Menopause Society says that for a true diagnosis of hypoactive sexual desire, which really means decreased desire that's causing problems in your life or your relationship, they say it can be used, and they recommend using either testosterone cream, which is available by prescription, or the products that are available for men for testosterone replacement topically at about a tenth of the dose. So we're using really tiny doses, which of course are very difficult to measure. And they say that providers should monitor our testosterone levels if we are taking that treatment to prevent too much testosterone. So what about safety? This is something a concern I hear quite a bit from my patients. And this is because of a big study that came out called the Women's Health Initiative, and that came out in 2002. And the authors of that study concluded that hormone replacement therapy, and they used the conjugated equine estrogens and one of the synthetic progestins called medroxyprogesterone that we talked about. They say they found that using the hormone replacement increased the risk of breast cancer and did not increase the quality of life in the women in their study. And so that came out in 2002, was highly publicized, and a lot of women just stopped using hormone therapy, and a lot of providers stopped prescribing it. However, since then, there's been a reevaluation of the data that has shown a lot of problems with that interpretation. First of all, most of the concerning side effects happened in the women in the study who were started on hormone replacement therapy when they were 65 and older, or more than 10 years out from menopause. When they really looked at the group of women who were started on hormone replacement therapy when they were younger than 60 or less than 10 years from the start of menopause, they did not see the increased risks of breast cancer that were touted in the study. So that reevaluation shows that the actual risk of breast cancer in women starting hormone replacement who are in that under 60 group and less than 10 years from menopause was only 3 cases per 1,000 women over 5 years of use. And that was using like I said, the conjugated equine estrogens and the synthetic medroxyprogesterone, which we really aren't using anymore. There's some experts who feel that the estradiol that we use now, that's very similar to what we make in our ovaries, and the synthetic progesterone that we're using now may have a lower risk, though we need more studies to show that for sure. And then they also found that even in the women who were just using estrogen alone because they had no uterus, they actually had a decreased risk of breast cancer, which is interesting. For either group, there was no increased risk of breast cancer mortality. So even in the women in the study who were on the combination hormone replacement therapy, if they got breast cancer, they were no more likely to die from breast cancer than people who weren't using hormone therapy. So, unfortunately, still, hormone replacement therapy is still not recommended for anybody who has had breast cancer. You should definitely talk to your provider. Other risks of using hormone therapy include blood clots, uterine cancer, but that's very unlikely to happen if you are taking progesterone with your estrogen, and gallbladder disease. But all of these risks pooled together occur less than 10 people per 10,000 person years. So that means if you followed 10,000 people for a year, you'd only see 10 of these adverse events. So pretty good safety profile. And like I said, it's most beneficial when we start it in women younger than 60 within 10 years of menopause. And then the other thing that I think has changed, definitely has changed since then on reevaluation, is this duration of treatment. It doesn't, hormone therapy, if you've decided to start it, does not need to be routinely discontinued when you hit 65. Really, it needs to be an ongoing discussion of risks and benefits with your provider. Of course, all of us change. We develop new medical problems that may make hormone therapy risky. So certainly if you have a stroke or a heart attack, your doc might talk to you about getting off your hormone replacement therapy. But again, it's not like a cutoff. You can only be on this for so many years and then you have to stop it. And it's definitely true that for, the risk to benefit ratio is is probably more favorable for those women who don't have a uterus who only take estrogen versus those of us who have to take both. So we'll just switch gears here. What about these non-hormonal therapies for menopausal symptoms? So usually we start with hormone therapy because these non-hormonal treatments really don't work as well, but they certainly are worth it if hormone therapy is not for you. All of these medications, of course, have potential side effects, which includes cost. And you just have to weigh those potential risks and benefits with your provider. So I kind of mentioned the first group, the selective estrogen receptor modulators. There is a product called Duav, which has one of these medications, bazodoxifene, I have a hard time saying that, with some conjugated equine estrogen. And that's for more systemic symptoms. And then there's, I mentioned before, ospemifene, which is specifically for vulvovaginal type symptoms you may be having. There's a brand new medication. The trade name is called Veozah. I'm not sure I'm saying the generic name right, but fezolinetant. This is really cool. They figured out that estrogen works in the brain with a neurokinin chemical that regulates our body temperature. So basically, this medication targets these neurokinin B receptors and that regulate the body temperature in the brain and to prevent hot flashes. So kind of cool. I hope it's promising that they're going to come out with some other medications and really be doing more research to figure out why all this stuff happens to us. Some antidepressant called paroxetine has been studied in a very low dose at 7.5 milligrams, and it's repackaged and marketed as Brisdel. And this medication has been shown to reduce the frequency of hot flashes by a bit. And it very safe. Of course, the Brisdel is a lot more expensive than the generic paroxetine. So most of us just prescribe the lowest dose of paroxetine because it's less expensive. And plus other medications in this family might also do the same thing. They just haven't been studied. And then there's some other prescriptions that we may use off-label, like gabapentin, which is actually an anti-seizure medication that we use for a lot of different other things like chronic pain. And it has a side effect of making people sleepy. So it's really nice to use at night because it has that sleepiness side effect, plus it may reduce your hot flashes. And then also very interestingly, oxybutynin, which is a medication that helps reduce urinary frequency and urgency. It can reduce hot flashes as well, and it's generic and very inexpensive. Then, of course, everyone wants to know about the herbal and food treatments. I think the short story here, and maybe a little disappointing to you, is there's really little to no evidence of the effectiveness or safety of any of these herbal or food supplements. Most of the studies that have been done on these products are very small. They've been very short. They have been done outside of the United States. and people who try to pool studies together to try to get a bigger population and try to make heads or tails of the evidence, that the studies are too heterogeneous or too different from each other, so they can't really pool them. So that's been kind of difficult. So more investigation needs to be done there. We'll see if that happens. Then, of course, things that certainly people try and can be helpful: cognitive behavioral therapies, mindfulness-based stress reduction, hypnosis. All of those might be interesting to people, certainly unlikely to be harmful. They may be expensive, but unlikely to be harmful. And then, of course, we all dressing in layers, bring a fan, bring a cold pack. These kinds of things can be helpful too. So in conclusion, I hope you'll walk away. I appreciate your attention. Hope you'll walk away from this talk really understanding that menopause is normal. Aging is normal. We are all going to get older if we're lucky. I always joke that no one's come back to tell me the alternative is better. However, bothersome menopausal symptoms are very treatable. You don't need to suffer. Please talk to your provider. And also, I hope you walk away with, for most of us, hormone replacement therapy. It has a pretty reasonable risk to benefit ratio, and it's worth learning more about. And then, of course, if that's not for you, there are other non-hormonal treatments available. And then this is just some resources online that are evidence-based. They have great patient websites. So the Menopause Society, I highly recommend. And of course, the American College of Obstetrics and Gynecology is a great resource, as well as the Endocrine Society. So thank you very much for your attention. I don't know if I need to stop this first, but let me just, yeah. So we're going to have some time for questions. So if you've had, do I need to read this now? Okay, I'll read this last. We'll do questions. Okay, stop share. There you go. Okay.
So we have a handful of questions for you today. So what are hot flashes related to biologically? Why do we get hot?
That's a good, so I kind of touched on that with this new medication. I think that's where this that medication came from, was research where they found that there are these chemicals in the brains called neurokinins that and I don't know exactly the relationship, but they work in the hypothalamus, which is it's in the pituitary gland at the base of our brain, and that gland regulates our temperature. And there's a feedback loop between estrogen and these chemicals. That, of course, when you lose your estrogen, that feedback loop goes away. And they think that is partially, that might be why we have hot flashes. But as far as I know, it's still incompletely understood. It's still it's still more than we used to know. We all used to know is it used to have something to do with losing estrogen. That was all we knew. So I think they're still trying to figure it out. But again, that's back to how they discovered that novel medication, that new medication, which is pretty cool.
What is brain fog?
Good. No one knows. It's a real thing. I think many of us experienced that if we were pregnant as well. And so nobody really knows, but it's definitely something real, definitely something to talk to your physician about. Again, not one of the things that hormone replacement is indicated for, and there could be multiple reasons why it's happening. So can't tell you exactly though.
If you are on birth control, will you still get periods regularly as you enter menopause, or will you eventually stop having periods even if I'm taking birth control?
So it depends. If you're taking your birth control cyclically, meaning you take the sugar pills on the fourth week, and so you're having a withdrawal bleed during that fourth week, yes, you will continue to have periods as long as you're taking birth control. Some women take birth control continuously and do not have a period on purpose because there's no reason to have a period if you're not trying to get pregnant. So those women wouldn't have a period and so usually what a lot of us, what the providers will do in consultation with the patient is as long as there's no reason to stop the birth control, we'll continue the birth control until you hit the average age of menopause. And we might stop it temporarily and kind of see what happens. If you stop your birth control and you start having hot flashes, There you go. You're in menopause. Or they might check your some of your hormone levels to see if it looks like you're in menopause. That might be the one group of people who might benefit from lab testing.
How can I stop from waking up in the middle of the night while going through menopause?
If I wish I had this answer. We don't know. I think there's a lot of reasons again why a lot of people, men and women, our sleep changes as we get older. There's multiple reasons why our sleep could be poor, alcohol intake, lifestyle stuff, stress going on in your life. And then there's menopause. So all of the usual treatments for insomnia, in addition to treating any menopausal symptoms, are very applicable for us. And they're the best treatments for insomnia, other than, like I said, treating pain or treating hot flashes that are keeping you awake, is cognitive behavioral therapies for sleep. And so definitely talk to your provider because the thing that keeps most of us awake is worrying about not sleeping.
Who do I talk to when I start noticing symptoms? A primary care provider, my OB/GYN?
Either one. I think I didn't mention that, but I think either one, if you're lucky enough to have a great relationship with uh, OB/GYN and or a family doctor, an internal medicine doctor, any of us can help you. So just talk to somebody. Don't suffer in silence.
What are general risks and benefits of hormonal replacement?
Well, I think we touched on a few of them. The general benefits are if you're having hot flashes, they'll treat the hot flashes. It prevents it prevents bone loss. And therefore, because you're helping the hot flashes, it might help your sleep. And like we said, there's a lot of potential other symptoms that we don't have great evidence for hormone replacement therapy helping, like mood changes, weight, skin and hair changes, those kinds of things. There's not great evidence for that. And those are not reasons to start hormone therapy by themselves. But really, it's the vasomotor, the hot flashes, maybe preventing bone loss. And then also, there's a decreased risk of diabetes for women who are on hormone replacement therapy.
What is the average age when a woman will no longer need hormonal replacement therapy?
That's a good question. Everyone is different. I have patients in their 70s who tell me I will pry this medication out of their cold, dead hand. Uh, I mean, it really depends. And then some women want to stop it because they just get tired of taking medication and they don't want to take it anymore. They don't feel like they need it anymore. It's really an individual decision that you make in consultation with your provider.
Earlier, you mentioned an increase in UTIs. Is there anything you can do or take to prevent UTIs from happening?
Yeah, actually, there's a lot of, besides hormone replacement that we talked about, certainly make sure we drink plenty of water. Many of us do not have as much of a thirst reflex as we get older, or we're having urinary incontinence or some other issue and we're just not drinking enough. Pelvic floor strength, actually, pelvic floor physical therapy can be helpful. Things like there's not great evidence, but things like cranberry juice or cranberry little pills can help acidify the urine and reduce your risk of having urinary tract infection. So there's multiple things that can be helpful that aren't really prescription medications. But again, if you're still having problems, talk to your provider because there are other things too.
What are the benefits of transdermal patches compared to pills?
Oh, that's a great question. I forgot to mention it. So there's when you take something orally, of course, it goes through your digestive tract and passes through your liver before it goes out into your bloodstream. And so there's some concern that because of that first pass effect in the liver, oral estrogen may have a slightly higher increased risk of causing a blood clot or these other adverse effects. And that if you do it transdermally or even transvaginally, because that's essentially transdermally, that there won't be that first pass effect, and therefore, hopefully, the potential adverse effects will be lower. Some I think it really comes down often to insurance coverage and personal preference. Unfortunately, many insurers, they make you pay more. The copay is higher for some of these transdermal products. I'm hoping that will change because some of the transdermal and the transvaginal products are certainly convenient. You don't have to take a pill every day. You only have to change a patch every week, every two or twice a week. And then the vaginal rings every 90 days. So very convenient.
How does an IUD interact with perimenopause?
Oh, good question. So IUDs can that you may have had for preventing pregnancy. Some of them release a little bit of local progesterone, and I think I don't put in IUDs myself, but I'm not sure if they're FDA approved for use instead of taking the oral progesterone, but some women do use those, like have an IUD to protect their uterus while they're taking estrogen in lieu of using oral progesterone. So some women will just keep that IUD if it's still good. Certainly, probably want to talk to your provider who provides the IUD about what's right for you, but they can be a very helpful tool.
How do you know if you have hit menopause if you have had a hysterectomy?
Yeah, that's a good question. You may not know for sure because, like I said, some women have absolutely no symptoms of menopause. So, but many women who have had a hysterectomy will start having hot flashes and other symptoms. So, again, that group of people might be in the group that may benefit from some lab testing if they're not sure. The only reason to do it probably is if you're having symptoms and you're not sure where the symptoms are coming from, and you and your doctor need to do an evaluation. But if you're not having symptoms, there's no reason to know unless it's bothering you.
What are the best resources in the Roaring Fork Valley for sorting out hormone therapy options? Any medical providers you recommend?
Hmm. Well, I certainly would recommend any medical provider that you have a good relationship with. I think that's the best place to start. So, like we kind of mentioned before, your primary care provider, which could be your family doctor or your internist, or of course, if you still have a relationship with an OBGYN, those are the best people to start with because they've been here, they know everybody. We all try to keep up to date with the latest literature, and they'll get you where you need to go, or they should get you where you need to go.
All right. Last question. How do I schedule an appointment with you? Where do you see patients?
I see patients at the Valley View Internal Medicine office here in the medical office building next to Valley View in Glenwood. And you can just call our office.
All right,
All
that is
right.
all the questions.
So I've been asked to read these announcements. So we'd love to hear your feedback. If you have time to fill out the quick survey, it will appear right after the webinar has ended. You will receive an email with a recording of this webinar within the next 24 hours. And the next Valley View University is next Wednesday, March 5th at 6 p.m. Valley Ortho's Dr. Neil Armstrong and physical therapist Jessica Galgiani, oh, sorry, Jessica, I just messed that up, will be presenting on foot and ankle injury prevention for returning to the trails. And thank you all very much for joining us and have a great afternoon.